Thanks for joining me today. I'm Chris Wallace. I'm a urologic oncologist at the University of Toronto, and I'm really happy to take a few minutes of your time to discuss prostate cancer screening and where we're at in 2024. So many of you will know that prostate cancer is the most common cause of a solid organ cancer diagnosis for men. And in Canada, that means that in the average year, almost 25,000 men are newly diagnosed with prostate cancer. And importantly, nearly 4,500 or more men are going to be expected to die of prostate cancer each year. And so this is really an important public health level degree of morbidity and mortality. And we know that when we introduced PSA screening or PSA testing as prostate cancer screening in the early 90s, we had a decreased incidence of prostate cancer mortality in Canada. That is to say that not only were we finding early signs of disease, we were actually affecting the overall mortality rate in our population. And so this was an important benefit to the community. However, there are numerous issues with prostate cancer screening, and the two foremost are overdiagnosis and overtreatment. And I want to talk to you a little bit about how we've evolved in our practice of PSA screening and managing prostate cancer in the past few years in a way that I think really reduces the burden of both of these on the community. So first, in terms of overdiagnosis, we've had a rapid evolution of management of these patients following PSA testing and prostate cancer screening, such that not everyone requires a prostate biopsy. So you'll see here the recent guidelines from the CUA, the Canadian Urological Association, really highlighting that based on the PSA level, we can stratify the intensity of our follow-up. And for those who have an elevated PSA, we can do numerous other tests in order to better risk stratify them before we move ahead with biopsies. So adjunctive testing options include the use of multiparametric MRI, numerous biomarkers or risk calculators and nomograms that all can contribute to better understanding a patient's risk of prostate cancer. The other approach we can take is in terms of the management of cancer once diagnosed. So we know that overtreatment and significant morbidity comes from the treatment of patients with low-grade, low-risk prostate cancer. These men have a relatively indolent natural history, and so they're at very low risk of dying of their prostate cancer, but we can certainly harm them through overtreatment and the morbidity of our treatments. And so over the last 20 years, active surveillance has become the standard of care for men with low risk, that is low grade prostate cancer. And in an active surveillance protocol, we monitor these patients with the goal of intervening and identifying any disease progression that would warrant treatment while really avoiding the harms of immediate prostate cancer treatment related to either surgery or radiation therapy. And fortunately, active surveillance has been relatively well taken up in our communities, and so the burden of localized prostate cancer treatment has dropped down. As a result, when we put these two big changes together, the updated CUA guidelines really suggest that PSA screening for prostate cancer should be considered for men with life expectancy over 10 years. And this is clearly not right for every man, and so a decision to pursue PSA screening needs to be based on a discussion between the man, his family, and his physician about the potential benefits and harms. And when we are looking at moving forward with screening, the population most relevant for this is going to be age 50 to age 69 in most. And certainly you can start a little bit earlier, maybe at age 45, and with an increased risk, either due to a family history or ethnic background. And when we put all of this together, we know that prostate cancer screening using PSA as a first step can reduce deaths from prostate cancer. However, when we do it poorly, prostate cancer screening has a significant burden of overdetection and the morbidity of overtreatment. And how we have fortunately seen in the last 10 or 20 years that improvements in both evaluation and treatment of prostate cancer can reduce these harms of overdiagnosis and overtreatment and really shift that risk-benefit balance to favor this for many, many men. I appreciate you taking the time to join me today, and I hope this has been interesting and informative for you. Thank you.